definitions and medical comorbidities, indications for surgery, restrictive versus malabsorptive procedures, post-operative care and complications, and finally, high-yield clinical vignettes. Section 1. Definitions and medical comorbidities. So what exactly defines severe obesity? We're looking at a BMI of 40 or greater. That generally correlates to an actual body weight about 100 pounds over the ideal. And keep in mind, central or apple-shaped obesity carries much higher risks than peripheral pear-shaped obesity. Why? Because that increased visceral fat drives up intra-abdominal pressure, leading straight to hyperinsulinemia and peripheral insulin resistance. Now, this disease process has a massive systemic impact. For your review, you've got to focus on the severe, highly testable complications. From a pulmonary standpoint, you absolutely need to know obesity hypoventilation syndrome and Pickwickian syndrome. Metabolically, look out for type 2 diabetes and non-alcoholic steatohepatitis. But here's the critical, hopeful takeaway. Nearly all of these medical sequelae are actually reversible once the obese state is resolved. Section 2. Indications for surgery. Memorize these exact cutoffs. To even be a candidate, a patient must have first failed intensive medical management and lifestyle changes. Then they need a BMI strictly greater than 40 or greater than 35 if they have weight-related comorbidities. More recently, patients with a BMI greater than 30 who also have poorly controlled diabetes or metabolic syndrome might be offered surgery, though we're still establishing the long-term data on that one. Just as vital are the absolute contraindications. You literally cannot operate on patients with untreated severe psychiatric illness, binge eating disorders, or active alcohol or drug abuse. Pay special attention to prohibitive operative risks, things like severe congestive heart failure or unstable angina. And this is a big one. Patients who are actively pregnant or planning to get pregnant within the next 12 to 18 months postoperatively are absolutely contraindicated for bariatric surgery. Section 3. Restrictive versus malabsorptive procedures. Okay, bariatric procedures essentially fall into two main buckets. First, we have restrictive operations. These physically limit the volume of food ingested. Think adjustable gastric banding and sleeve gastrectomy. Then, we have malabsorptive operations. These bypass predetermined lengths of the small intestine to actively block nutrient and calorie uptake, like the biliopancreatic diversion. The Roux-en-Y gastric bypass is actually the most popular procedure in the United States, specifically because it combines both of those restrictive and malabsorptive mechanics. The surgeon creates a tiny 30 milliliter proximal gastric pouch, performs a very tight 1 centimeter anastomosis to a roux limb, and completely bypasses the distal stomach, duodenum, and proximal jejunum. And the outcome of this combined approach? A massive 70% mean excess weight loss. When it comes to total weight lost, this is demonstrably superior to purely restrictive procedures. Section 4. Postoperative care and complications. Write this pearl down right now. Perioperative mortality is thankfully low, sitting at about 1%, but despite aggressive mechanical and pharmacologic DVT prophylaxis, pulmonary embolism remains the single most common cause of mortality after bariatric surgery. Early ambulation is totally non-negotiable. This next point is a classic exam favorite. If your post-op patient has unexplained tachycardia, you must promptly investigate. Why? Well, because unexplained tachycardia is often the very first, and sometimes literally the only early presenting sign for either a pulmonary embolism or a devastating anastomotic leak at the gastrojejunostomy, which happens in about 2% of cases. Never, ever ignore a fast heart rate in these patients. Remember that an early or late bowel obstruction after a gastric bypass is a surgical emergency. The anatomy has been fundamentally altered, which carries a super high risk of internal hernia and rapid bowel strangulation. Your definitive diagnostic test here to evaluate for both leaks and obstructions is a CT scan with oral contrast. Section 5. High-yield clinical vignettes. Let's lock this in with a vignette. We have a 29-year-old female, just 4 days post-bypass. She's got severe abdominal pain, vomiting, and check out those vitals. She is tachycardic with borderline blood pressure. A CT scan reveals distended small bowel loops. So, based on what we just reviewed, what is the next step in management? The correct management is immediate intravenous fluid resuscitation and prompt surgical exploration. You cannot sit on this. This is driven entirely by that high risk of internal hernia and bowel strangulation we literally just discussed. Serial abdominal exams or upper GI studies will just waste precious time you don't have. Okay, let's look at the next scenario. A 37-year-old woman presents 10 weeks after a laparoscopic adjustable gastric banding. She has obvious obstructive symptoms like severe heartburn, nausea, and vomiting for a week. Crucially, the vignette notes her band was tightened at an office visit 2 weeks ago. She's tachycardic with epigastric tenderness. What's the next step? The immediate, life-saving solution here is removing all fluid from the band's reservoir. You absolutely must relieve the acute obstruction before obtaining imaging or starting medications. This perfectly demonstrates the unique complication profile of purely restrictive adjustable devices. Finally, consider this presentation. A 45-year-old woman presents full year after her gastric bypass with epigastric pain. An endoscopy reveals a 1.5 centimeter marginal ulcer near the gastrojejunectomy. What are the primary culprits associated with this specific late complication? The primary culprits are NSAID usage, H. pylori, smoking, and poor tissue perfusion or ischemia. This is exactly why you must strictly counsel your patients that non-steroidal anti-inflammatory drugs are to be completely avoided lifelong following bariatric surgery. The source material makes it totally clear. Surgical intervention remains our most powerful, durable tool against the obesity epidemic, capable of literally reversing severe metabolic disease processes. But given the rigorous follow-up required, from completely avoiding NSAIDs to lifelong vitamin supplementation and monitoring for internal hernias, are we, as a healthcare system, truly prepared to manage its lifelong consequences? Something to think about. Until next time, keep crushing your review.